only by following a very comprehensive public health mitigation strategy are we going to be able to, it's just realistic. I mean, without the vaccine, like this is another kind of thing that's coming, right? But until we are all able to get the vaccine, we still need to follow these mitigations. The vaccine's not going to be available to everyone immediately, right? So normal people who are just, working from home, or even young, healthy people won't be able to get it till like further down in the rollout. So we still need to practice public health mitigation strategies, masking, social distance, washing hands, these things we need to still do.
Ladies and gentlemen, thank you so much for joining us. I've got not one, but two epidemiologists on the line here. And the goal is going to be twofold. We're going to start with some of the common misconceptions and some of the common myths around COVID, and hopefully use that to educate ourselves about what the actual biology and the actual epidemiology is surrounding this pandemic. And then we're going to try and pivot to where do we go from here, both from a public health point of view, from a scientific point of view. And we're very, very lucky today because we've got Dr. Katrine Wallace, who is more on the academic epidemiology end of things. And we've got Maddie Lewis, who's much more on the clinical and seeing patients, public health end of things. So guys, welcome to the podcast.
Thank you for having me.
Thank you.
Before we go on, can we just go over your qualifications here to have an opinion, just so people know where you're coming from, and just so they can have some kind of confidence that you guys have a background in talking about this stuff? Or are you just going to admit that you got your entire education from watching YouTube videos? Dr. Wallace?
I'll go first, yeah. So my name is Katrine Wallace, and I work at University of Illinois at Chicago. I got my PhD in epidemiology in 2013. And I have an academic appointment at the same. I just couldn't get enough, so I stayed. And I actually had been in their master's program before that. So I've been at University of Illinois for many years.
Okay. And what do you do on a day-to-day basis?
So on a day-to-day basis, my kind of emphasis area in my degree was aging, diseases of the aged. And so that mostly it's cancer and oncology is what I study on a day-to-day basis. But since COVID is a disease that severely affects elderly people, I ended up working a lot on COVID and sort of getting pulled.
Okay. And yourself, Maddie?
My name's Maddie Lewis. I work at a state health department doing COVID and foodborne epidemiology. And I work part-time because I'm a full-time student. I'm in my last semester of my master's program. I'm getting my Master of Public Health degree in epidemiology, which is like the standard degree for epidemiologists in the United States. And I make epidemiology and political TikToks.
Okay.
But yes, that's another one of our qualifications too.
Yeah, we both make TikToks.
Well, why don't we put your TikToks out there right away so that if people want the abbreviated version of this interview, they can just go to your TikToks. They can scram and go watch those.
So mine is epidemiologist Kat.
K-A-T.
Mm-hmm.
Mine is at maddy.epidemiology.
Okay. And I imagine that almost all of what you're talking about on your TikToks is COVID now. You're not talking about other epidemics going on.
I'm glad there aren't any other real crazy epidemics going on, but yes, mostly it's I talk mostly about COVID and epidemiology. Maddie does a lot more of the kind of health policy, public health, more interesting stuff than I do because I'm not qualified to talk about it, but she knows a lot more than that, given her position at the health department. She's more privy to that information.
So why don't I throw out some myths or some objections or some questions, depending on where they're coming from. And if you could both tee off on them, that'd be awesome. I think we'll learn a lot. So the first that you hear a lot is something like COVID is 99.997% survivable. And then that number changes to COVID is 99.5% survivable. And it's this definitive number that's usually quite low. So, Dr. Wallace, would you care to comment on this low lethality, high survivability of COVID?
Sure. So that number was pulled from a document on the CDC website that was called a pandemic planning scenarios document. And it's a document that's really meant for public health professionals, and it's got data in the document that kind of speaks to infection fatality ratios, which basically means the number of deaths over the total number of infected people, which means asymptomatic plus symptomatic people. So the problem with these numbers is that we don't have that data yet on the asymptomatic population, at least in the US, because we're not testing asymptomatic people for antibodies on a population-based level. So the data in these reports, that it was put out there as sort of a planning document. So like if the numbers in it are estimates based on, data from China. So it's really kind of, until we have a real handle on the number of asymptomatic cases we have by doing population-based serology testing, we really aren't going to know what the infection fatality ratio is because we don't know the denominator.
So that brings me, I guess, to two questions. Number one is, there have been local attempts to estimate what the infection fatality ratio is. I mean, early on in the pandemic, Dr. Ioannidis did that study in California and came up with a very low number that's then been republished. And that was based, I believe, off of a Facebook survey and then doing a bunch of antibody studies and trying to estimate for a local area. And then other countries and other populations and other scientists throughout the world have done this. And the last time I looked, it looked like most of them were saying, hey, it looks like the infection fatality ratio is somewhere in the 0.5 to 1 point something %. So if you have 100 people and they all have COVID, then on average, one or half of one is going to die. What do you think about, and then you've got a few extreme outliers saying, no, it's actually 0.2%. But most of them seem to be in that 0.5 to 1%.
So the reason I hasten to answer is because we see different serology percentages in different places. Like when they went to Sweden to try to see if their approach had worked, they found that it's like somewhere between like 15% was like the highest they found, and that was among like essential workers, I think. In New York City, same thing. It was very, very low prevalence of antibodies. So it's really difficult to kind of know if that's the capture is well done. And so there, like you said, there have been a range of studies, and I think probably the best estimate we have it from what I have seen is about 10% of the country has been exposed or whatever, based on like an average of all these different kinds of studies. So it's really difficult to answer the question without a really good population-based study.
Okay. I mean, I guess we can tell it's less deadly than the Black Plague and more deadly than the flu.
And then to kind of further dovetail off that, there's two different ways to measure fatality rates, right? So there's the infection fatality ratio, which we're talking about, which requires a real good knowledge of the asymptomatic population. And then there's the case fatality ratio, which is a different measure. The numerator is the same, number of deaths due to COVID-19. The denominator is, instead of all symptomatic plus asymptomatic cases, the case fatality ratio only uses the symptomatic cases, the people that tested positive for COVID, as the denominator. So that seems like it would be easier to do, but the problem is we know that COVID is associated also, and this affects both CFR and IFR. It's associated with long-term complications, which unfortunately some are lethal and people will still die from them. So it took us like 3 or 4 years to get a good CFR estimate for SARS because of the long-term complications that were directly from the disease, but just weren't acute, they were after the acute sickness.
Okay. Maddie, in your line of work, kind of in the policy end of things, how important is IFR, this infection fatality ratio, or the CFR, the case fatality ratio? Like, I imagine if the number was super low versus super high, that would make a huge difference to what you do on the ground.
Yeah, I think if the mortality of COVID was similar to that of, let's say, the H1N1 swine flu, then this pandemic would look a little bit different. But for health departments, you have to remember that we're used to collecting data the year after it was collected and then analyzing it then. This pandemic is so real time. So the data we're collecting is not very accurate. And that's okay because we can still make good decisions based on data that's not complete.
So, Maddie, you were talking about it being relative to other diseases. Now, forget about swine flu, forget about MERS. Say it was, I'll throw the next objection out there. Hey, this COVID is no more deadly than the flu. How do we know that this is more deadly than the flu, Dr. Wallace?
Well, I mean, it's very easy to objectively look that up. I mean, when I get that question, I'm kind of like baffled by it because, as Maddie was saying, we have some very bad flus and no one's minimizing. And she's the health department person, so she can tell you there is an entire part of our healthcare system, public health system, that is set up just to track influenza. No one's minimizing that that's a very big health problem. And we've had some really bad seasons. Like she was mentioning 2009, we had a very bad H1N1 outbreak. We had another bad influenza, 2017, 2018, that was actually associated with some excess mortality that year. However, even though that is a very major public health issue, we've lost more people due to COVID-19 in 8 months of 2020 than in the previous 6 flu seasons. So you can just look at the numbers and see that it's more deadly. I mean, and we're not even done with 2020 yet.
Mm-hmm. And on a major uptick.
One of the best measurements to prove this point is excess mortality, excess all-cause mortality, which is the mortality rate that scientists are really good at predicting what mortality is going to look like from season to season, year to year. And during a really bad flu season, we will sometimes see a slight uptick in all-cause mortality and excess all-cause mortality. And in 2020, that uptick is huge. And you can see that on the CDC website.
Yep. Yeah. And what she's talking about is in 2017, 2018, you see a little peak of excess mortality because we had a very virulent strain of influenza that year. But it's shadowed by what we have this year.
Well, I can vouch for that being a bad influenza year because I had to go to the hospital for something orthopedic and just some kind of injury. And walking through the hospital or hobbling through the hospital and just seeing patients lined up on either wall, wearing masks incidentally, and the whole place essentially being ground to a halt. And I was lucky to go see the orthopedic guy I needed to go see because he wasn't in the emergency room treating people who couldn't breathe. So even a bad flu year is pretty bad. But you're saying it's worse than 6, so far it's worse than 6 flu years, the last 6 flu years put together, and it might end up being a lot worse.
In terms of mortality, absolutely, yes. Okay. So when people say flu, we get this kind of conspiracy theory almost that the flu, that COVID is just like the flu and that it's, it's just like a flu and that we should just live our lives because it's, just like the normal flu. But there's a lot of reasons why there's a problem with that assumption. The first is that we have some immunity to the flu because we've all had the flu and the flu has been around, and we might not be immune to every strain of the flu, but we have some immunity and our body remembers, even if it's a little bit of a different strain. Right. So there's that natural immunity that we have. Second is that we have a vaccine to the flu, which we get annually, or we should get annually, which, if you still get the flu, can lower the severity of the flu that you do end up getting. And then the third thing is we do have treatments that are kind of effective for the flu. We have none of that for COVID-19. It's a novel virus. We have no antibodies. We have no vaccine. And we really don't have a lot of treatments. We have some for in-hospital patients, but mostly it's just recover at home. So to say it's just like the flu is really kind of not, it's absolutely wrong.
Okay. Another objection would be, goes along the lines of, scientists are underreporting the flu and they're calling every case of the flu COVID so that they can get more funding, or for whatever reason, to scare people into wearing masks and taking vaccines, to turn their bodies into antennas so that Bill Gates can control their mind with 5G or something. But the core concern is that flu in 2020 is being completely underreported. Look how the flu numbers crashed as soon as COVID came out. And every case of the flu is being called COVID. Maddie, do you admit to this?
Are you doing this at your health department?
Right. So those conspiracies are absolutely so silly. So it would take thousands of employees for that conspiracy to hold up, not to mention just health department employees, but also physicians and nurses and all these people in between. So that in itself should show that that is just ridiculous. But also, health departments can track flu in various different ways. So at some health departments, I assume that influenza is what's called a notifiable disease. At all states, COVID is a notifiable disease. So what a notifiable disease is when a lab gets a positive result for COVID, then they are required by law to send it to their state or local health department. And so health departments are really the hubs that collect all of the COVID data, the majority of it. And then they will send that to CDC for the nationwide data.
I'll just pivot to Dr. Wallace and ask her, is there any chance that people testing for coronavirus, or COVID-19, are actually measuring flu patients? Because there are coronaviruses that are flus, but not all coronaviruses are COVID-19.
So there are actually not coronaviruses that are flus. There are two distinct diseases. Coronaviruses, there's common colds that are coronaviruses, but influenza is its own kind of thing, and it's genetically distinct from COVID, from coronaviruses. So the tests that are testing for coronavirus are not picking up influenza unless you have a co-infection, which can happen. But I think the answer to your like, where is the flu kind of conspiracy that's been going on online, there have been reports. And I think what happens with these conspiracy theories is that you hear little bits, they come from something. They're always from something that's like, there's a grain of something true, and then they get kind of times 1,000, right? So what happened with this one was, we did see a decrease in influenza in the Southern Hemisphere this year. And the reason for that is the Southern Hemisphere has their flu season opposite ours. So their flu season was when we were having our summer in the Northern Hemisphere. So like June, July was their winter. They did have a more mild season because it was kind of the peak of their mitigations for COVID. So some of the countries were on lockdown. Some of the countries were, there was one publication that had Australia, South Africa, and I think Chile were three countries that had a much more mild flu season. And that was attributed to the fact that mitigations for COVID, another respiratory virus, were helping keep those numbers low, because people were staying at home, they were wearing masks, they were social distancing, all things that also will reduce the flu incidence. So people hear that and then they think, oh, well, wait, where's the flu? Like, that's a conspiracy. So that got exaggerated. Another thing is that people look at the flu incidence in the US kind of like, when this started blowing up as a conspiracy theory, was like September, and that isn't flu season here. So there really is always a low incidence of flu back when that started kind of being prevalent on the internet. So if you look at the flu season, there's like a curve, and it starts to pick up like around now, actually, and it peaks in like January, February. It starts to get more, it just starts to pick up, and then it gets it peaks in January, February, and then kind of trails off as we head into the spring. But so we really haven't had a chance yet to say if we have less flu or not.
Mm-hmm. I would be not at all surprised if this was a record low flu year, given that very roughly half of people are taking precautions.
Agreed.
Let's say that's correct. Let's say half of people are social distancing, not hanging out in groups, staying home when they're sick, wearing masks. That's going to greatly cut down on the number of regular flu. Even if I'm not suggesting we do all that stuff for the flu. But
no, right. But no, you're right. But because it's another respiratory virus, the same mitigation strategies that work for COVID-19 also work for influenza. So that's why the Southern Hemisphere, during the peak of when they were mitigating, same with us, but we just weren't in our flu season then, right? So they've already seen those results. And so I want to go back to what Maddie was saying about things being a notifiable disease. Another thing about COVID is right now we're trying for complete ascertainment of COVID cases and deaths. So that's not happening with the flu. With the flu, like she was saying, is we use kind of a sentinel surveillance, like we'll test hospital blood samples to get like prevalence. We have certain sentinel surveillance centers where we'll test all the blood samples from certain places across the US that are representative. And this has been validated. But we don't have, like when people say, oh, well, we're not testing for flu, we're only testing for COVID. It's because we use this validated sentinel surveillance system that we've used for years, and we know it works, and we can estimate. That's why when you see influenza, like numbers from previous years, it always has a standard deviation around it because it's an estimate based on these systems that we use. Okay. And eventually we'll get there for COVID too.
Yeah. I'd like to throw this question out to both of you. There's this claim that the scientists or the CDC or the WHO or they just want you to lock down forever. There's a million variations of that.
No.
Okay.
We all want to go on vacation.
Could you respond to what it actually is? You know, there's that movie. What do women want? What do scientists want?
I don't like lockdowns. I'm not a fan of them. And I say that because in the United States, the government essentially refused to give people the adequate resources to have a proper lockdown. And so we couldn't properly lock down. So I'm a fan of lockdowns. Well, actually, I'm not because they're not fun. But that would have been a necessary part of the pandemic, like we saw across Europe and in Canada, a more complete lockdown where the government can actually give people resources. But in the United States, because our government has not been operating the way it should, then it just doesn't work the same. And that's why we have these problems still. So no, scientists, we want to go on vacation. We don't want to see the economy be harmed, but we also recognize that the economy can't bounce back when there's so much COVID because people aren't willing to go out and spend money. Small businesses are hurting because their employees are sick, and we have to recognize that. So we're between a rock and a hard place, and we have to take the least harmful option, which is to deal with COVID.
I'm not suggesting that we as a society move to the Chinese model, but they were partying in government-approved parties in large groups in Wuhan, the center of the epidemic, I think in June. And they're doing a lot of partying now in New Zealand and Australia. So this narrative that lockdowns don't work, it may or may not be a tool that we want to use. But to say they don't work, Dr. Wallace, I think it was you who said that the goal that lockdowns represent the failure of public health measures, of the more benign public health measures. You know, it's when you, is that not something, I'm attribute that to you.
I don't know if I said that, but I agree with what Maddie said 100%, is that we weren't able to do a proper lockdown like New Zealand did. New Zealand was paying their their citizens to stay home, and it worked for them. They have no COVID anymore, and they have a very strict, their borders are sealed. So if you're going home to New Zealand from another country, you have to quarantine for 14 days in a hotel. I mean, they're very serious about eliminating COVID. Same with Australia. They did a very strict lockdown, and now they're very serious about the quarantining. We never really did anything like that. And the thing that is kind of disheartening is that people kind of turn on the public health system and say, like, I get accused a lot of not caring about the economy and these kind of things, but as Maddie was saying, like, unless you kind of follow the science and eliminate COVID, we the economy is going to be bad no matter what. Every time we've tried these mass open ups, it has not led to good things. So only by following a very comprehensive public health mitigation strategy are we going to be able to, it's just realistic. I mean, without the vaccine, like, this is another kind of thing that's coming, right? But until we are all able to get the vaccine, we still need to follow these mitigations. The vaccine's not going to be available to everyone immediately, right? So normal people who are just, working from home, or even young, healthy people, won't be able to get it till like further down in the rollout. So we still need to practice public health mitigation strategies, masking, social distance, washing hands, these things we need to still do.
Do you think, or do you know of data that proves or indicates that if a reasonable percentage of people wore masks, did basic social distancing, and avoided large public gatherings, and washed their hands, and there was some kind of contact tracing, I think those are 4 or 5 mitigations,
yes,
that would be sufficient to keep this thing at a dull roar until there's a vaccine? Or do we really need that lockdown?
I mean, we definitely know that it would work. The problem is that people, and I don't know if it's human nature or what, we can have all the public health recommendations in the world, but but we only are allowed to enforce those things in public. So it's kind of difficult, because you can say, Wisconsin has a mask mandate. So what does that mean? That means when I go out in Wisconsin, I have to wear a mask when I'm in a store. It means that if I'm like walking, in a public park, I have to have a mask on. But when I go to, my aunt's house and she's having a dinner party and we all don't have our masks on, there's no way to enforce that. And in my area, and I don't know about Maddie's contact tracing data, but in our health department, 2 out of 3 new cases of COVID are happening in people's homes where people were gathering without masks on with people they know. And that's why Thanksgiving was such a humongous concern to public health organizations around the country, because we were all scared, because we know this is what's in the data. So the public health recommendations are kind of one thing, but people following them is a separate issue, and that's not happening.
Okay. Maddie, do you have anything to add to that?
Yeah, I would say COVID denialists like to use this excuse that, oh, well, this city has a mask mandate, but there's still so much COVID and COVID is still going up in that city. Why is that so? And the answer is, like, you can put a mask mandate in public and it's certainly undoubtedly helpful. But when people still gather privately, then that's where the transmission is going to occur. It's going to occur somewhere if people are gathering.
Yep.
Mm-hmm. Now, one other strain of denial goes something like this. Yes, cases are going up, but this is a casedemic. These are all just cases. They're not deaths. Where are the deaths? And then sort of an alternate variation of that is there are only more cases because we're doing more testing. Those are two similar but related questions. So I'm going to put them together. So is this a casedemic? Where are the deaths? And number 2, is there just more cases because there's more testing? And if that's the case, then what's the right metric to be looking at?
So, I mean, I hear that all the time too, and it actually kind of makes me angry when I hear the casedemic logic, because there is 90,000 people in the hospital right now at this moment while we're talking for COVID-19. Most of them in ICU. ICUs are full. There are healthcare workers in North Dakota being asked to work while they have COVID, taking care of COVID patients because they don't have enough healthcare staff. So hospitals are full. So when people are saying the hospitals aren't full and there's no where are these patients, like you can go on the COVID tracking project every single day and look and see how many people are in the hospital for COVID every day. And you can see right now it's 90,000 people. And if you look at the curves on that website every day, the deaths are also go on an upward trend. And one thing to remember about cases and how they are related to the other indicators is that cases happen first, hospitalizations happen second, and deaths are the trailing indicator. So it's like there's 3 peaks so that you have, so that's why another reason Thanksgiving scares us, because we had exposure on Thanksgiving. Cases come next when people start to have symptoms. Then there's hospitalizations come third, where, we've already just talked about how hospitals are at a breaking point and really can't take any more people in some areas, like like El Paso and North Dakota. Like there's areas that really are in trouble setting up COVID units in conference rooms and things like that. And then the deaths will be the final trailing indicator of all of that. And another thing that is concerning about all of this is that if you get in a car accident or you're in a fire in a big major city and their ICU is full, where do you go? Like you don't have COVID, even if you're working from home and being really careful, you could have some other reason you need to go to ICU or the emergency room.
What are the general lags between those peaks of getting COVID, getting diagnosed with COVID, turning into a case, the case turning into a hospitalization, if that's going to happen, and the hospitalization turning into a death, if that's going to happen?
Yeah, so from exposure to case is anywhere between 2 and 14 days per the literature. It varies based on the person. Most cases, like we talked about, will never progress to hospitalizations and deaths. Most cases will be managed at home with just, supportive methods, cough drops, humidifiers, this kind of thing. If it is going to go to a hospitalization, it would probably be like around days 10 through 14. And then to the death, it varies completely based on the case and the person.
So the big Thanksgiving, let's assume there was a series of super spreader events on American Thanksgiving. I'm Canadian. So American Thanksgiving is November 30th?
It was, what day was it? No, it was.
It changes every year.
It was the 20th. I think it's the last Thursday of November. So this year was the 26th.
Okay, the 26th.
Yep. But you guys had your Thanksgiving on
we have it way
October.
Earlier. Yeah.
But you also saw a surge after that in Canada.
We did.
That's why we used that data in the US to warn people because we saw that, because Canada prior to that had been doing quite well.
Yeah. Things really went for a giant poop, shall we say, after Thanksgiving. And it was, I live in British Columbia, where we were feeling pretty smug about ourselves at that point. Look, cases are low, cases are low, cases are low.
And people gathering. Yep. It's a person-to-person transmission. When people gather, it's going to transmit. And it's just common. Like you were talking about at the very beginning of the podcast, the biology of the disease is that it spreads from person to person. So the more people and the less mitigations you have in place, like if you're at a house with no masks, no social distancing, and you're indoors with no ventilation, it's kind of a recipe for disaster.
So when would we expect to see the deaths from Thanksgiving peak?
So like I said, the deaths can vary based on like how long the person that's a little bit less easy to predict. But I mean, usually it's, we'll see a jump in cases and hospitalizations probably pretty soon, because that was almost a week ago. So cases, I would say from Halloween and Election Day, we're dealing with that still with the hospitalizations, right? So we had a big surge after Halloween and our election day, all that went along with that. And that was end of October, beginning of November. And here we are, beginning of December, and we're still sort of dealing with those hospitalizations.
Okay.
And they're still continuing to increase.
Are you seeing the same thing where you work, Maddie?
Yeah, so we can't see upticks for usually 2 weeks at least because we have data lags. So health departments in the United States tend to be underfunded, understaffed, etc. And even though those labs are required by law to send us the positive lab reports, often there's a time gap. It can be a week, it could be 4 weeks. And sometimes we even get our labs through fax and through snail mail, which
What is a
is
fax?
really obsolete. So those time lags are real. They can happen 2 to 6 weeks typically. Not to mention if there was a Thanksgiving gathering, let's say, and then those people went out and infected other people,
Yes.
that spread can take time, not to mention the up to 2 week incubation period. So we could see it 2 to 6 weeks at least, but further down the line, it's probably just going to keep growing throughout the winter. And I have no idea when the winter peak, so to speak, is going to happen.
Yeah. I mean, being a firefighter, I always think of this in terms of September 11th. And I mean, there are lots of predictions that we're soon going to be seeing basically September 11th, or 4,000 people a day die. Do you think that's possible? Do you think that's realistic?
I mean, we're seeing 2000s now. Mm-hmm. So in the US, I hate to say it, but this disease is exponential, right? So what we see is exponential curves in cases, in hospitalizations, and sometimes in deaths too. So the more exponentially the cases rise, everything else kind of rises too along with it in proportion. So that's the scary part, is that this disease has we call it an R naught value in epidemiology. It's like the reproducibility value, how many people each person is going to infect. And it's much higher for COVID-19 than for influenza. That's another thing that's important to distinguish between the two diseases. Influenza, it's higher than 1 sometimes at peak flu season. But if you have an R0 value or an R naught value of 1, it just means each person's going to infect one other person. And you'll still have spread, but it won't be exponential spread. If you have less than 1, the disease will kind of fizzle out. And that's what happens at the end of flu season, is that the R naught value kind of trickles out and it's like 0.79, then it's 0.6, and then the disease just fizzles away. What happens when it's over 1 is that each person is infecting more than one other person. And that's when you have exponential spread. And that's when you have problems. And that's what we have with COVID-19.
Now, I realize the R naught value depends on what people are doing. I mean, if everybody did go hide in their closet and close the closet, the R naught would be 0.
Yes. Only one variable within that is the actual disease itself. That's correct.
But what are we seeing over the last 9 months that we've been dealing with? What kind of range of R naught are we talking about with COVID? And compare that to the R naught of the flu, say.
So when we talk about the R naught, like you're saying, that it's a wide range. So we tend to use averages, which are more applicable to some places than other places, because transmission happens in more densely populated areas more than in rural areas. That's why it's extremely concerning right now in the United States that we have such uncontrolled spread in rural areas, because that never needed to happen. So we mostly say for COVID-19 based on the literature, and most of this literature actually at this point is from China, but like we have some updated estimates that it's kind of can be anywhere between 2.5 to over 3. For the flu, we see R naught values of like 1.2 at the highest.
Really? So that's quite transmissible. It's no measles, but it's pretty
No,
damn
no, the measles
transmissible.
is crazy.
Yeah,
Yes.
measles is insane. If a measles case goes in a room with 10 people unvaccinated for measles, they'll give it to 9 of them.
Okay, so that's yeah. That's is there anything more infectious than measles? I'm sure there's some obscure virus in the depths of the Congo
The
somewhere.
most infectious or the most contagious I've ever seen is measles. Have you seen a
Okay.
R naught higher than measles, Kat?
Mm-mm.
Okay. So, what about the people who point to something that somebody in the CDC said, or one thing that uh, somebody in the WHO said, and say, see, they said XYZ in April, and now they've changed their mind. They're lying to you. Is are they lying to us? And does changing your opinion mean that they were lying? I framed that far too
No, no, no.
partisan a
I'm
manner.
trying to. You want to
Like
take that one,
I
Maddie?
can't
Sure.
I can't stand it.
Scientists base their opinions, or they should be basing their opinions based on facts and evidence. And so our opinions and our interpretations of those facts and evidence change as the facts and evidence change, which they certainly have over the last 8 months of this pandemic. So people will pull things that Fauci or the Surgeon General of the United States things that they said back in March and use that as quote unquote proof or evidence that COVID's actually not a big deal or whatever. But their opinions, their interpretations of what this pandemic is have changed. And that's just showing that science is working, that we're updating. So the process is working. If we find out more information about COVID, which we do every day, then it's showing that the process is working, that we're discovering more.
So we're converging to a truth. We didn't start at the truth, and we're probably not going to end at the exact truth, but we're getting gradually closer.
Exactly.
And I think it's important to point out that, and what Maddie kind of alluded to this, is that this is science in action that we are living every day. And people aren't used to that. We aren't used to the science moving so quickly and being able to experience it in real time in such a public way. Like, usually we're in our labs or at our computers doing science and nobody's kind of privy to it, right? But public health scientists have been at the forefront of this pandemic, and Dr. Fauci, who, he's been at the forefront of other epidemics, but not in such a public way. So I feel like people don't understand that this isn't a normal time. And it's not like people just like, oh, I'm going to say this today and then tomorrow I'll say something else just to confuse people and mix it up. It's not like that. It's very much people learning as we go. And the statement that Dr. Fauci made in March about, well, you don't have to wear masks, that gets still in people comment that to me every single day online. Well, Dr. Fauci said we didn't have to wear them, so why do we have to wear them? Well, when he said that in March, we had absolutely no idea that we had asymptomatic spread of COVID-19 because that's not an issue with influenza and other respiratory viruses that we have. This level of asymptomatic people prevalent in the community. We didn't have that with other respiratory viruses. So we really thought if someone's sick, they'll stay home and that's going to fix the problem. But, if that's why if everybody wears a mask, then that issue is controlled. But it's very unfortunate that that's been sort of blown out of proportion.
I I also have a problem with people cherry picking something that somebody in the CDC, how many people are in the CDC? I don't know. I'm guessing more than 1,000.
And
How
they
many
don't
people?
all work on COVID either. That's the thing that's so funny is like the CDC is humongous. And the reason you don't know what else they work on is because successful public health science is silent. You don't notice it. It's like the reason you don't know about it is because it's working, right?
It's the same problem that, I'm sure there's some military units working to shut down terrorist attacks
And we
that have
don't hear
actually
about
succeeded,
it
and we
every
don't hear
day.
about
Yeah,
it.
exactly, because it's
And
working.
so now, why are we funding this unit again? Because they actually did their job.
Exactly. Good public health work is invisible. We always say that.
So the argument has been made that that we have treatments for this that are being suppressed. I mean, the hydroxychloroquine is the classic example. Hydroxychloroquine. Why isn't more attention being paid to hydroxychloroquine? It's because, apparently, that the really expensive treatments like remdesivir, that the big pharma wants to make money with that. Big pharma wants to, or then the more extreme version of that is that big pharma wants to give everyone a vaccine to turn your body into an antenna. What about the cheap treatments? Why isn't hydroxychloroquine being used? It's so cheap.
So hydroxychloroquine was granted an emergency use authorization kind of at the beginning of this pandemic because there was anecdotal suggestion that it might work. And an emergency use authorization by the FDA is granted in a time when there's unmet need in a kind of an emergency situation, like the name suggests. And it was given to patients. There was many studies done. A meta-analysis was published in the Annals of Internal Medicine. I think it had like 17 studies in it. And it studied two different dosing regimens. One was just hydroxychloroquine alone, which showed no effect. The meta-analysis of all those studies together, which ended up, the meta-analysis is like a big study that they combine data from different studies that are published to make it like you have a big study. There was no effect shown in that meta-analysis of hydroxychloroquine alone. The arm of the study with hydroxychloroquine plus Z-Pak, which is azithromycin, the combination therapy, actually showed a 27% increase of mortality in that study arm.
Meaning more people died than if they took it.
Yes, correct. So there was a 27% more, it was a 27% increased risk of mortality. So the FDA revoked the emergency use authorization because there was either no effect or increased harm in the patients that it was being used for. And, it's been online, I see data is being censored and it's not censored. It's all published. It just isn't positive. So it wasn't put onto the clinical guidelines and it wasn't approved by the FDA for use.
Can you talk a little bit about that censoring of data? Because it's a common accusation. So if I had the statistical wherewithal and the time, which I don't, to look at the actual studies that were done on hydroxychloroquine, could I get my hands on all that data and reanalyze that data?
So probably if you contacted all of the authors for all the publications, but the paper that I was talking about in the Annals of Internal Medicine was a meta-analysis that just used the published data. So it's pretty good. And even the studies on their own weren't that compelling. I think there was one that was sort of suggested that there would be an effect, but that was out of like 17 studies. So there's one outlier that was positive.
There was that infamous demon semen doctor, which I can talk about like that, which you may or may not be able to in your professional role. And she claimed to have had 300 or so COVID patients and they'd had 0 fatalities. So then there's lots of like anecdotal, I want to call them studies. They're not really studies, but anecdotal data sets, which suggest that
yeah, so that's the problem with that, right? So where is that data? If she has that data, we would love to see that. It's like, where is it? And that's the thing, is like, we get a lot of that. Well, this person has data and this doctor in France has patients and this doctor, you hear these people on the internet talking about these doctors that have these hundreds of patients, but if they have the patients, then publish the data, because I know personally from my own perspective, anytime I see a publication about treatment for COVID patients, I read it right away. So I would read that with interest.
Well, I guess the argument is the scientific journals are suppressing those studies. Sorry, Madeline, you were about to say something.
Right. So if that actually happens, then any scientist, any doctor that had such a great outcome with a drug would be so excited to readily publish that as quickly as possible. but we're not seeing that. And of course, there's always going to be one or two studies, outlier studies, that show maybe it does help, but it's really about the quality of evidence and the amount of it. And so what we've seen is that hydroxychloroquine clearly doesn't show a benefit for COVID patients.
I think people also don't understand the idea of statistical significance.
Yeah, and the quality of evidence that she just mentioned is actually extremely important as well.
What do you mean by quality of evidence?
So there's a pyramid, right? So the top of the pyramid would be like randomized clinical trials would be like the gold standard, the top tier evidence. And then as you go down, there's observational studies like cohort studies where you're following two groups over time, but it's not blinded or randomized. Then there's like, case control studies where you look, you figure out, okay, this person had this disease, this person didn't, and we look backwards. So retrospective observational studies. And then you go kind of down the pyramid, and like the very bottom level is case reports, right? Just like anecdotal cases. So it's like the strength
where
of the
would mechanistic sort of mechanistic studies being like, in theory, if somebody takes hydroxychloroquine, it's going to shut down this transporter on the cell wall, and that'll allow zinc to go in or out, and
so mechanistic studies I almost consider to be a specialized form of clinical trials, because you do so whether or not they're randomized, I guess they could be either clinical trials or observational, depending on if they're randomized or not. Like so it's a pretty high level of evidence, but if you don't have a comparison, that's another thing that affects your level of evidence if you don't have a group to compare to. So a lot of the mechanistic studies are just a one-armed, sort of almost like a one-armed cohort or a registry type of design.
I think we're in danger of going too deep down the sort of
I could go on and on and on with study design, so you got to cut me off.
I mean, in the time that I spent doing biological research and doing my master's, I screwed up a whole bunch of experiments because I had incorrect study design and incorrect statistical analysis. It's really easy, completely unintentionally, to screw this up, right?
Yeah.
You do a bunch of samples in the morning when you're fresh, and you do a bunch of samples in the evening when you're tired and bleary-eyed and exhausted. And as a result, you're measuring slightly off in the afternoon compared to the morning. And if in the morning you just did one bunch of treatments, in the afternoon you did another set of treatments, maybe the results that you're getting are just because you're tired, or just because you did the measurements in the morning and your lab partner did the measurements in the afternoon. I had that happen. And this idea that, what science generally uses, I'm imagining in health science, you use the whole that a study is significant if it's 1 in 20 times, if you would get that by random chance. Are you still using
0.05?
0.05?
Mm-hmm.
So
in epidemiology, we are a little more forgiving. So sometimes 0.05 is still the standard for biomedical publishing. But when I'm doing my own analysis, if I see like a 0.08, I know something's going on with the data there, and we want to look at that still. Anything from like, I would say we're a little bit more liberal just because we can see that there's something going on, but 0.05 for publication is still the biomedical standard.
Could you explain what this 0.05 level of significance is? Could you mansplain that to my audience?
Can I mansplain it? So basically it just means that there is a 95% chance that what you found in your study, whatever estimate you are making, there's a 95% chance that is not due to random error.
Okay. So if I had a treatment where I put a pyramid on someone's head to cure COVID, and I do 20 different studies like that, 95% significance would mean that I would expect one of those studies to show an effect.
Exactly. So there's always going to be outliers. And the things, and what you're bringing up is important too, because if you have a treatment like that, like putting a pyramid on somebody's head, and you're finding some significant results, you need to also think like, are there other things I need to control for in the analysis? Because now this is a really like wacky example of how this can happen, right? So we know that's not going to help.
It's not nearly close to the wackiest thing I've heard today.
No, but I'm just saying this is a really good example for illustrative purposes for your audience, because seeing a pyramid on somebody's head to treat a respiratory virus, we know that's not going to work. So if you see that those results are saying that it does, like that means we need to dig deeper. Like, what else about these patients are we not controlling for? Do all these people, work in a meat packing plant, and that one person that didn't get COVID with the pyramid, do they stay home all the time? Like, is there something else we're not measuring? So that's what we do in epidemiology, is we look and see, like, kind of what's statistically significant, and then we control for other things in the model, and then see if that result is then attenuated by controlling for other things. And a lot of times you find something in like a univariate analysis, so you're just looking at one thing versus another thing, and it's significant. But then once you start controlling for age, smoking status, obesity, then those significant results go away because there's all these other confounding factors. So you have to be really careful, and you have to be really, when you're reading a publication, you have to really understand the method section and exactly how the research was done.
This was basically the go-to accusation. When people think that there's this grand conspiracy, that there's this red telephone that rings in the lab of every scientist, and it's them telling you what you should find. When I was doing my honors undergrad, there'd be these Friday afternoon sessions where scientists would come in and present their findings. And it was a sport to tear apart what they would bring in. It was a competition. And one of the go-to attacks was that their statistics were off, and that had they detrended for something that was going on, like what you said. And so the level of scrutiny that these studies are put under is pretty high, but it can get into esoteric land very, very quickly. And I don't know how to convey that to people other than to send home the big message that really, when somebody, if you, Katrine Wallace, put something out there, everyone's going to converge on you like a bunch of piranhas to try and tear it apart. And then if it's left standing at the end of that, well, then I guess she has something.
Right. And there's also another thing that we need to consider too. There's the hierarchy in data quality, like Maddie was referring to with different down the pyramid. There's the quality of data, the top being clinical trials and the bottom being anecdotal reports. Then there's also peer review. So there's study design quality, and then there's journal quality. So if you're finding an article and it's in like lockdownsarebad.org, and it's talking about how, lockdowns cause all these awful problems and that COVID isn't real, like, that's probably not a peer-reviewed source, right? So
I'm trying to think of that Chinese study, or that study that proved that it was in that the Chinese had developed it.
So yes, that's a perfect example. So you need to be very careful, because like when you're citing a reference, like what we were just talking about with hydroxychloroquine, the Annals of Internal Medicine is not going to publish something that's garbage, right? They're going to have a very strict peer review process that's going to have people that are like kind of experts in the field reviewing this article. And those people have no interest in the research at all. They're separate people. And I get asked to review articles, and it's a lot of work. And sometimes I don't want to do it, but I feel like it's a way I can be of service to my field, right? So I do it, and it is a lot of work, and you have to pour through all the methods, because you don't want to make comments that are dumb comments, right? You want to make sure that what you're doing is adding to the quality of the paper. So any journal that's worth its salt, that's publishing things that's peer reviewed, is a much better source than like a blog article or
YouTube
like
video.
or YouTube.
Facebook
Exactly.
posts.
So exactly. So that's why when I do my TikToks, and I know Maddie does too, we always put our references on the TikTok or in our link tree, because it's very important to me that people look at me and say, okay, she's saying this, but and a lot of people will come to my page and say, well, why should I believe her? And I always make sure that I have all the references and resources at their disposal, because I want them to not listen to me. They can like take me as a starting point and then kind of a launch off to being able to research it on their own.
Well, let's pivot from here to this idea that hospitals get paid more money for reporting all deaths as COVID, slash, you know, the story that I've heard multiple times, and it's repeated so faithfully, it has to be an urban myth. But the story goes something like, my friend's father went to the hospital with cancer and died, and the hospital called the family and offered them money to change the diagnosis to COVID.
I'll let Maddie take this one since she's the health department person offering all these big payouts.
Yeah, I love working for the deep state. So hospitals get paid, get reimbursed for COVID hospitalizations, correct, Kat?
Mm-hmm.
It's hospitalizations or deaths.
They don't get, nobody gets paid anything when somebody dies. It's
no
only
deaths, just the
yes.
hospitalizations. Okay. So individual physicians and individual workers at the hospital don't get anything. Their salary stays the same. So this idea that individual doctors are signing off death certificates left and right because they get more money is absolutely untrue. Their salary doesn't change with the types of patients they have.
Yeah. So the CARES Act in the United States does allow for a upcharge for COVID-19 patients, and that is because of the cost that it was the cost that was taking to care for these patients, especially in the spring. Additionally, the CARES Act pays for uninsured COVID-19 patients, which was to just these are people that don't have any insurance other ways. And it also pays for COVID testing. So the CARES Act was actually a very good piece of legislation because it actually gave access to healthcare for people that wouldn't have otherwise had it during this pandemic. Unfortunately, because of that, it's been sort of twisted into like, oh, well, doctors are just miscoding so they can get this upcharge on the bills. But like Maddie was saying, this goes to the hospital, not to the actual physician. So there's no incentive for a physician to do that.
So then a more sophisticated critique of it would be, fine, okay, the doctor makes the same amount of money, but it's the hospital administrators putting pressure on the doctors, or the hospital administrators secretly changing it because the hospitals are making less money now that they aren't bringing in elective surgeries.
That's the ironic part, is that people think the hospitals are cashing in, but they're actually not. It's not going well for them. So that's not possible to happen either, because there is, in order to code and get a case, so the CARES Act is administered through HHS, which is basically Medicare. So in order for 8 months of Medicare fraud to happen, it's just not going to happen. There's a coding kind of threshold. So the person doing the coding needs to see a COVID-19 diagnosis. They need to see COVID workup. The whole thing, a hospitalization needs to be a COVID hospitalization for a coder to mark that as COVID, right, in the medical chart. So there's that. And then it gets submitted. And if they see a bunch of like bogus claims that look like they have their heart attack, claims that just are marked as COVID, so those aren't going to go through. And it was really astounding to me when, even at the end of the campaigning, when President Trump was even saying this was happening, in some of his campaign rally speeches, he was saying that doctors were marking things as COVID because his administration is administering the CARES Act. So they have a list of all these reimbursements that have happened. So if that was really a concern, they could have been checking that.
The next level of butting that would be, but the hospitals are making less money. We acknowledge that because we couldn't, they couldn't do their regular number of, I don't know, whatever, elective surgeries. So, of course, they're going to be faking some of the numbers. And then the government's kind of in on it too. But
it falls apart there, though. It falls apart because the government's paying. So why are they in on it? It just makes no sense. Like, it goes to a certain point where they're like, they think they got you. And then you're like, but wait, the HHS is the ones, kind of paying these out, and Medicare is investigating all Medicare fraud does happen, okay?
Sure.
And they have task forces set up to work on it. It happens, and it is a problem. 8 months of systematic Medicare fraud for the same exact problem? No.
Yeah. All right. So it is entirely possible that someone somewhere
Sure.
had died of a heart attack and got miscoded. But
I
I mean,
mean,
I know
there's
when
no
my
there's no way that it would be systematically paid. And then also going back full circle to the beginning of our conversation for what Maddie was talking about with the excess mortality, if all those cases were just other things being miscoded, why would we see 300,000 excess deaths in the US starting in March? I mean, it just makes no sense that.
Well, let's circle back to the excess deaths, because some people have made the argument that COVID deaths in the United States anyway are being undercounted by somewhere in the 25% range. There was a really good article in Scientific American, I want to say the end of October, that didn't, it's not a study in itself, but it summarized other studies.
It was a nice piece. And I think it's probably true. And we saw that if you look, there's a nice data visualization on the CDC website of New York City, and it has confirmed cases. This is just from March to like May or something. It was like confirmed cases, suspected cases or probable cases, and then excess mortality. And it's the same, the three curves are exactly the same shape, but the excess mortality is over and above what we see for confirmed and probable.
Wouldn't we expect things like suicides and drug overdoses to go up and then that end up in the excess mortality curve? That yes.
That's another downfall of a pandemic is, and we've seen this with Ebola in Africa, is people won't seek medical care or can't when the hospitals are overwhelmed.
Yes.
So we typically will see excess mortality for indirect clinical events.
So a heart attack that would have been preventable means I die in the ambulance as it's circling the block trying to find a place to dump me off.
Or just at home if someone's too afraid to go because they think they're going to get COVID, or delayed medical procedures that would have been life-saving, like elective surgeries, maybe not elective necessarily, but scheduled surgeries, maybe were not happening. Things like that. There's another piece of research from the CDC where they looked at excess mortality, and they kind of dug in and looked at kind of what they looked at the all-cause mortality at the excess and quantified that, and then they quantified how many cases we had in the provisional death data to COVID-19, and it was about 66% of the excess deaths was COVID. So that leaves a third of the excess mortality due to these other factors. So that's why when people kind of accuse us of thinking everything's COVID, we're not doing that. Like we recognize, like Maddie was saying, that there are other causes of death that are associated with the pandemic that are not COVID.
Yeah. Well, that Scientific American piece did a nice job of converging, or sort of looking at three converging strands of evidence, only one of which was excess mortality, if I remember correctly, suggesting that on average the deaths are probably being undercounted, not overcounted. Let's pivot to masks. This is something that I've really gotten a ton of grief for online. So I don't know how to phrase this objection. I think the simplest way to phrase it is masks don't work. And then some other ways to say that is, look at the size of the holes in a mask. The virus is so much smaller than that. This morning I heard I'm going to fart right beside you and you're going to put on your N95 and you're still going to smell it. So how do we know that masks work? And I guess by masks, we got to differentiate like surgical masks / bandanas versus N95s. I think people who are going to argue N95s don't work, we're not even going to address. I mean, N95s, the science behind them is so incredibly good.
Yeah.
We test them all the time in the fire department. We put tiny little particles in the air and detect the concentration difference between outside the mask and inside the mask. And the mask manages to pull those particles out of the air. So let's not even talk N95s. Let's just talk bandanas.
Masks.
Yeah, cloth masks / surgical masks. How do we know they work?
So masks, what we know about masks is that masks work as source control. People that feel masks do not work are people that say, well, my sister's uncle's dog was wearing a mask and they still got COVID. Like this, there's a lot of anecdotal reasons why masks don't work. But what we do know is that masks work as source control. We have over 70 studies now showing that masks, and what do I mean by that? So masks work to keep my respiratory droplets in and not out in the community. When I talk or when I sing or yell or, all the time, little respiratory droplets are coming out of my mouth. The mask keeps them in. It doesn't keep me from getting COVID. That's why masks work when everybody wears one. It's to keep your own respiratory droplets in. And there's a profound misunderstanding of how masks work. People think if I wear a mask, it's protecting me. And it does to a certain degree by lowering the amount of virus that you kind of can breathe in. But the primary source is to protect the community from you.
A big misconception about masks too is that the virus can just kind of go through them. Like,
yeah, talk about that.
Yeah, so I'll see pictures on Twitter of like a metal gate with these big gaping holes, and it's just like, oh, COVID can just slip through it. But the thing with COVID and respiratory viruses is they don't just float around in the air willy-nilly. The route of transmission is two different ways, like respiratory wise. So we have respiratory droplets and we have an airborne transmission route. Respiratory droplets are a bit bigger. They come out when you talk, really have a little cough in your throat, sneeze, whatever. Everyday things, you don't have to be sick and actively coughing to emit them. You emit them all the time, whether you're at the grocery store or whatever. And so the virus primarily for COVID, our best evidence now shows that they are primarily in respiratory droplets. And so what the mask does is it acts as a barrier to catch those respiratory droplets of the person wearing the mask. And then to some extent, it can act as a barrier for people around you, their respiratory droplets, but just not to the same degree. And then there's also an airborne route, which we call them aerosols. So they're essentially respiratory droplets. They're just the really small version of them. And those are tricky because those can stick around in the air and linger for a longer period of time. We see that with measles, chickenpox, tuberculosis, other airborne diseases. COVID likely has an airborne route. It's still slightly debated, but our best evidence now shows it's primarily transmitting through the respiratory droplets, and there is some aerosol transmission as well, which like restaurants, gyms that don't require masks, indoor areas where the mask is going to be off for a certain period of time, even airplanes to an extent for people eating an entire meal on an airplane. That's why those enclosed congregate settings can be so dangerous, because even if you're wearing a mask 95% of the time, you can still get COVID when you take off that mask for a short period of time. And especially if it's indoors, those aerosols can kind of accumulate.
Yes. And the aerosols will hang in the air a long time after the person has left too. So you might not even know that somebody had been there with COVID.
The analogy I heard, tell me if it's correct, is that the aerosol component is much more like cigarette smoke. If you walk into a room 10 minutes after somebody's been smoking in there, you can still smell it. We can't smell COVID-containing aerosols, but it kind of behaves in a similar manner for hanging around. Is that
But the
correct?
way it hangs in the air, yes, it'll be in the atmosphere, like sometimes even I've read hours after the person is gone.
Now, I see a bit of an all or nothing thinking in people going, man, even if masks stop 80% of transmission, you're still going to get 20% and then you're going to get sick. If one virus particle gets into you, you are going to get sick. And so why even bother? Can you talk about the dose-dependent response?
So there's well, first of all, that is a criticism that even with a mask you can get sick, and even if everybody wears masks we can get sick, and that's true. That's why masks are part of a comprehensive public health mitigation strategy, which includes social distancing, hand washing, wearing masks, staying outside instead of inside, all of those things, quarantining when you're exposed. Super important. All the things, that's kind of like a Swiss cheese model, right? So the virus is coming through the Swiss cheese. So each layer can be penetrated, but all together you have a strategy that can, like, there's more barriers between you and the COVID-19 if you're putting these mitigations into place. So anytime somebody's asking me, is this safe or is this safe? I always ask them, it's not like you're ever going to eliminate risk, but you need to you need to assess the risk based on how many of these Swiss cheese layers you have in place. So like Maddie was saying, in a restaurant where it's like enclosed small restaurant where you have your mask off eating and you're talking really loud because there's music playing or something, that's, you have like basically no Swiss cheeses in place, right? But if you're outside and you're sitting 6 feet apart, there's more, you have more barriers there. So it's like you always have to assess your risk based on how many mitigation strategies you can put into place with certain activities. That's why some activities are safer than others.
Well, driving a car is dangerous, but you don't drive a car not wearing your seatbelt with your
Absolutely.
airbag shut off, with no brakes, on a slippery icy road while you're drunk at night with your headlights off. I mean, there you're looking for an accident. You might still die if you do everything right, but
So
the
car
odds of it
accidents
happening.
are a great example of public health mitigation strategies because we have all those things. We have speed limits, we have seatbelts, we have drunk driving laws, we have all these things that we have to do. We have lanes that we need to drive in, right? All of this is public health because we have been responding to accidents, and car accidents are
But
actually,
freedom.
yeah, my freedoms. Yeah, well, car accidents are actually very low. People always say to me, well, more people die from car accidents than COVID, which is not true. We get like 37,000 car accident deaths a year, and that is a public health success story.
Okay.
Yes, and I want to add on to what Kat was talking about with the Swiss cheese model. So that is really how masks work to mitigate COVID on a population level, and then more on the individual level.
Oh yeah, he did ask that. I didn't answer.
Yeah, so in infectious disease epidemiology, we look at a measure called a minimum infectious dose. So each infectious disease, it's not just like, oh, you're exposed, you get the disease. You're not exposed, you don't get the disease. It's much more complicated than that. You have to be exposed to a certain amount of virus or bacteria or pathogen to even get sick. And then some diseases, I believe COVID acts this way as well. The more exposed you are, the more you have a higher risk of getting more sick. For example, salmonella acts that way. If you eat a super rotten piece of chicken, then you're going to get more intensely ill than just a piece of that rotten chicken, right? So masks work to cut down the amount of aerosols and respiratory droplets. They, especially homemade masks and surgical masks, like the flimsy ones, they don't work 100%. We know that on the individual level. And N95s, of course, are like the best because they work by cutting it down as much as possible. But it doesn't need to be 100% for it to be worth wearing.
There was some interesting science a couple of months ago that I didn't follow. My plate's just too full. But it was some preliminary lines of evidence showing that countries that had more mask wearing might have kind of more presence of antigens, meaning that it kind of act like by getting just little tiny doses, because other people are wearing masks and you're wearing a mask, so you're getting, 10,000 virus particles instead of 100,000, that you're having a real low-level antibody response, and it's almost like a kind of immunization, kind of
Right.
like
It's
a
like
vaccine.
they call it variolation. And Monica Gandhi published that. It's a hypothesis that was published in the New England Journal of Medicine. And it's an interesting hypothesis. We obviously don't have any data on it,
Okay.
but it is like just getting that little bit of inoculum to the virus, like through the mask.
Mm-hmm.
Is it producing some kind of immune response? We don't know, but it's a very interesting It is a really interesting hypothesis.
We'll know in a couple of years, I suppose.
Exactly. When we have a perfectly good infection fatality ratio, we'll know
Well,
that too.
well, somebody pointed out we're still learning things about smallpox, and we're still learning things about tuberculosis. And those things have been around for thousands of years, and this freaking
Exactly.
illness has
Thank you
been
for
with us for
pointing
9
that out,
months.
because that's what a lot of people don't appreciate, is that we've had years to study some of these other diseases, and we've had mere months with COVID-19. Brand new virus, brand new everything. And the science has just moved at such a lightning speed, and these vaccines are truly a triumph of science. I mean, they really are. The speed and the, efficacy that we've been able to have in the time that it's just amazing to me that how fast science has moved, and that it's really truly amazing to me.
It is. The vaccine is insane too, because I remember at the beginning of the pandemic thinking, oh my God, it's going to take at least 2 years. And here we are, not even a year later, with possible approvals here around the corner. And not only that, but the fact that there's several vaccines that are showing over 90% efficacy, when easily this could have been just a complete fail. This could have been 20% efficacy.
For sure. And the FDA only was asking for 50, right?
Yeah, 50 was going to be the minimum threshold for the FDA to even approve a vaccine. But we're 90 plus % is so ideal. And of course, those measurements will probably change slightly once it gets distributed to a wider.
Are the vaccines going to change your DNA?
Does not change your DNA.
Could you explain an mRNA vaccine?
So I will just say right now, I am not a virologist, but I do know that the messenger RNA that the vaccines are being made from does not invade your cell or change your cells in any way. It just deals with the spike protein on the surface of your cell. And you're the biology person, not me. But it just alters the spike protein on the surface of the cell enough to confuse your own immune system into thinking you have an infection. And it doesn't even stay, the mRNA doesn't need to stay in your body very long, and it degrades, but your body learns the immune response from it.
I agree that I knew the answer to that one beforehand. I mean, there's the nucleus where your DNA sits, and it basically shoots mRNA out as a message. The message going out doesn't change like you being on a telephone and me calling you and talking to you doesn't change my telephone. It doesn't change the wiring in the telephone. I mean, I'm sorry, I should remain the neutral observer here and just ask the questions.
It's true. That's I mean, but basically, yes, it doesn't invade your cell at all. It just works with the spike protein, which the reason that's significant is that the spike protein on the surface of the cell is what the virus attaches to. And that's why we're concerned with altering the spike protein.
So Maddie Lewis, you admitted that this vaccine has been moving at warp speed. You admitted that it's been very, very fast, much, much faster than you thought, or most of the rest of the world thought, or Dr. Fauci thought that it would come out. So how do we know it's going to be safe? Isn't this thing just being rushed to market for the profit of the vaccine companies without regards for public safety?
So public safety and the efficacy are the biggest concerns, of course. So how vaccines work, they usually take they can take anywhere from 5 to 15 years to be developed. A large part of that is red tape, publishing, waiting for things to be approved, and editing and things of that sort. We're still following the exact steps that we usually follow, which is studying the vaccine in a lab and test tubes, and then moving on to animal models. We have to do 2 of those, and then moving on to a small amount of humans, and then larger subsets of human populations. So we're still doing all the scientific things. It's just those, the publishing and the writing and the approvals are moving at warp speed, because it's in everybody's best interest, not just the not just the pharmaceutical companies, but anybody taking the vaccine, for small businesses, for the government to stop spending so much money on COVID. It's really in everybody's best interest to get this vaccine out as fast as possible, as long as it's safe and effective. So I'm not super concerned with the safety of the vaccine. I know how this process works, and I trust the process because we've been doing it for years and years. And we've had vaccines for decades, right? So we kind of know, from my understanding, with vaccines, typically those adverse events tend to occur close to the time around when you got the vaccine, not super down the road 10, 15 years later. And so because of the clinical trials, I'm pretty confident. And I think it's 30,000 individuals were in the phase 3. And so that makes me pretty confident. Of course, there's always, for every medication, for Advil, for Benadryl, for those over-the-counter things, there's always a risk of something negative happening for a population of people. But so there's no doubt about that. But am I super concerned? No. Will I be getting a vaccine once it's approved? Absolutely.
Me too. Yes, that's an important point that she made, that these trials are huge. There's 30,000, 40,000. I mean, they're very large trials. And, yes, we will be continuing to follow these trial participants up for 2 reasons. One, we want to see what the long-term side effects are. But as Maddie said, most of the side effects that we see in vaccine trials are around, during the actual trial, or like a month after the injection at the very most. In these trials, about 10 to 15% of the participants reported side effects were what they deemed significantly noticeable. And these things were things like fever, chills, muscle aches, headaches, or like a flu-like kind of syndrome. That's been what's been reported. And I think it's very important to be transparent about that, is that there can be, even with the influenza shot, some kind of just malaise after you get it, but it's very short term and it's self-resolving. But yes, these trials, so that's the first thing they're going to follow up on. Second thing that they need long-term data on is the duration of response, meaning how long does this vaccine last? How long does the immune response last? So that will also be determined over time.
Okay. I think the level of vaccine resistance is going to be off the hook for this one, and people like Alex Jones appearing on Joe Rogan, I think the last time he was on Joe Rogan was busy peddling the story of how the Democrats are shuttling children to moon bases to sexually abuse them.
My God.
And then the next time he's on, he's talking about vaccines and
I just don't understand why it's easier for people to believe things like that than actual science and data. Like, if you're going to believe something, I mean, that's just outlandish to me. I just don't understand it.
Or if you believe something, believe one crazy thing, but not all the crazy things. I mean,
exactly.
I understand it. Yeah, and I run into some people like that, which gives me some hope for humanity. Somebody who believes the established science on pretty much everything, but then doesn't think lockdowns work. Okay, we can discuss this one thing, but to discuss everything, and then you find out that they're like denying germ theory as well, and like, oh
yes. And with this vaccine, you're going to get the intersection of anti-vaccination people with anti-COVID, like COVID denialism. So it's like a sort of a cross. There's going to be that
COVID denialism is already a merger of the right wing with the spiritual woo-woo wing, right? Like,
yeah, that's true.
Yoga people going, all you need to do is balance your chakras, and right-wing people going, my body, my choice, freedom. And now you're getting the anti-vaxxers coming in. It's going to be a dog's breakfast.
It is going to be a challenge. I mean, I mean, all I can do on my side as a public health scientist is to keep educating people on, what to expect, be honest and transparent about the adverse events that are being shown in the trials. I think that's important to be open and honest about, that there are 10 to 15 percent of people that are finding that they have these kind of flu-like symptoms. And just to keep kind of reiterating the importance to public health. We need to, anybody who is able to get a vaccine really should, because there are a lot of people that are too old, too sick, or too young to get a vaccine. So I feel it's the rest of our duty to protect them.
Let's just talk one more myth, and then I want to go, we've beaten the subject to death, but I think it's really important. And then we'll go a little bit into moving forward. What about this idea of herd immunity? And I see this popping up a couple of different ways, not vaccine-induced herd immunity, but either Swedish herd immunity, or we should let all the children get sick so that we develop herd immunity there. So those are kind of the two strains of herd immunity. What about herd immunity and just punching through this till we get to herd immunity? Dr. Wallace, go.
Well, I whenever I start to talk about this, I actually kind of get a little bit angry because so trigger warning. I actually, when the Great Barrington Declaration, this document that was put out a few months ago, by
can you go through the Great Barrington Declaration?
Sure. It's basically a document that was put forth by an organization that was funded partially by, I think, the Koch brothers or something. And it was a document that stated that we really don't need like lockdowns or any kind of like sort of public health measures, that we can just kind of allow the healthy people who won't otherwise die of the virus to kind of like just be out doing whatever and not taking any kind of precautions. And then we kind of lock away the sick and the old, infirmed people who would be at higher risk. So at first blush, I mean, it sounds like it would be like something that would make sense. But when you really think about the complexities and how as a society we are all interconnected, it really would not work. Like even the people, like first of all, the old people that they're talking about in the document, they are not all limited to nursing homes. There's a lot of people in the United States living in multi-generational homes, especially in neighborhoods where there are a lot of essential workers as well. There's a big overlap there.
So poor neighborhoods.
Which has been a problem in my city with exposure and quarantining elderly relatives within the home has been a big part of the education in my city with public health. So that right there makes me know this wouldn't work. Even the ones that are in nursing homes, younger people work and come and go from the nursing home. So there's just no real way to make this work in any good way. And just the way that the document is sort of, I just feel like these herd immunity approaches make me angry because they sort of devalue human life a little bit. Like it's like, okay, well, these people were going to die anyway, so we're just going to live our lives, and then whatever happens to them happens to them. If they want to stay in their house, that's fine, but if they go out, they can just so I don't have to wear a mask at Chili's. These people should have to stay home. I just don't like it. It's not a public health mindset.
Sweden. I've had people post.
So Sweden. So Sweden had an interesting. The problem with Sweden is they have in their constitution that they aren't allowed to have a lockdown. They actually weren't able to do something like that there. So I don't think their public health people did kind of put forth that they might be able to get to herd immunity, and they've been on record saying that, but now they've actually dialed that back, saying that wasn't a good strategy. And they've actually had a higher death rate in Sweden versus their other Scandinavian neighbors.
And just about as much damage to their economy.
Oh yeah. So it really didn't, that was not a public health success story. So the only real way, the herd immunity approach is not a the reason it bothers me so much as a public health scientist is it's not a public health approach. It's a very selfish approach that devalues certain segments of the population in favor of other segments. And I feel like as a community, we are all connected and we all need to work together using the Swiss cheese model. All of us, you need to use that because a community includes all different types of people. Plus, we have in the US, about half of our population has a comorbidity. So who are they locking away? Like everybody? Like, I mean, there's autoimmune disease, there's, people with heart disease, obesity.
You can't lock away people with obesity. That's like 50-60%
it's everybody,
of the population.
Yeah, right? So it's just it was a document, the Great Barrington Declaration, that was put forth with no data. It was just kind of put out there, and then people kind of glommed onto it like this is what we need to do. But it really in the practical society, that it would never work, and it's just unethical.
What would happen if, damn the ethics, we went ahead and did it? Like, would we actually reach herd immunity on this, or do we? Are there other diseases that we have?
We don't even know, because we don't know enough about COVID to even know how long the immunity truly lasts, and like how much of that immunity lasts. So we could try it, and then in 3 years,
and millions of people would die on the way to trying.
Yeah, it would be a disaster, first of all. And second of all, in 3 years, the virus could mutate or the immunity could wear off, and then we would have to go through it again. But on the way to get there, it would be so disastrous because we would have hundreds of thousands, probably millions of deaths in America. We would have, right now we're seeing people
more than we already have.
Right. Already we're seeing people with permanent damage to their bodies.
Yes.
We're seeing people called long haulers with longer term effects, and we don't even know what's going to happen 5, 10, 20 years down the line. For example, chickenpox. An example where people wanted to become naturally exposed so that they will have immunity. Well, chickenpox is different because once you get it, it's really, really hard to get it again. With COVID, we're not even sure if that's the case. Well, we have seen actually instances of reinfection. We're not sure how common that is, though. But anyway, with chickenpox, people would have what's called chickenpox parties. They would purposely infect their kids so that they would just, quote unquote, get it over with before the vaccine came out in, I think, 1995. Now we have a population of people who are dealing with shingles because we know that chickenpox is associated with this longer term health complication decades after you've had the infection. So will we see that with COVID? We have absolutely no idea. And I think a lot of public health people, myself included, are really, we really do think that there might be something, considering all of the horrible clinical things we've seen already with the permanent damage and the long haulers. So there's a lot there. It would completely harm the economy. It's already harming small businesses because when people get sick, they can't go to work. Why do you think health insurance companies pay for their employees through employee health insurance? They pay for flu shots. Why it's almost always free? It's because it's cheaper to pay for a flu shot than to have your employee get sick and miss work for a week. Mm-hmm. There's so many factors here.
Well, didn't polio also essentially start out as basically flu-like symptoms, and obviously then there's post-polio syndrome where you can barely walk. I think polio was an example of something that was pretty benign at first for most people and then came back with a vengeance.
It's just, yeah, and that was a really great point, is that we haven't touched on in this podcast yet until she just said this, is that mortality is not the only bad outcome here. So the herd immunity approach really would be a disaster for so many reasons. And our healthcare system already can't handle what we have. And who knows what's going to happen? The next crest of this might be all these complications, we're having renal failure, cardiovascular issues, respiratory problems, all this stuff's going to, be COVID-19 really could become a chronic disease in addition to this infectious disease, because we're finding these chronic problems happening after.
Okay. So let's pivot a little bit to moving forward, let's start on kind of the scale of, presumably some people are still listening to us. They are convinced that COVID is real. And the people who are convinced that COVID is real are surrounded by people who think that it's unreal, that it's a hoax, that it's overblown, that it's a tool being used by the government, et cetera, et cetera. So what do we say to people, and how do we convince people who are unwilling to accept that any kind of personal sacrifice is required in a situation like this? The analogy I use is, imagine if during the Blitz in World War II, the decision to put your lights out in the city of London was left to the individual. And the individual was allowed to make their own risk-benefit decision. Well, I think this risk from German bombs is overblown, so let the cowards, let the people who are afraid, let the old, let the weak, they can put out their lights. I'm going to keep my lights on. That obviously doesn't work during the London Blitz. But I am at a loss to try and convince people that their personal so-called rights should take any
really,
kind of infringement.
It's really astounding to me as a public health person. That's my mindset, is community health, and like wanting to make sure everyone in the community is healthy. And if there's something I can do to help somebody, and if it's wearing a mask, then that's easy for me to do. It's not like I'm being asked to donate an organ or something. I'm just being asked to wear a mask. And so to me, it's almost astonishing to me that so many people are unwilling to do something that's so easy that could actually save lives. It's very crazy. And this attitude of like, well, they would have all died anyway. And like this just callous disregard for human life is really astonishing to me. And I actually don't even know how to answer your question, because I find this all the time too. People either in my comments or kind of coming at me saying like, well, all those people would have died anyway. And this is, I don't even know what to say to that. Do you, Maddie?
No, I really don't know how to get someone to become empathetic. I don't think that's my job. But what we can do is find arguments and kind of perspectives on this issue that people are more privy to. So like economic arguments is something that I like to try to talk about, even though I'm not an economist, because I think we're seeing people more concerned with the economy than they are human life, unfortunately. And although the economy is important, I don't know why you would put that above human life, right? Yeah. So being able to show like there's a clear economic benefit to mitigating COVID, and people yes. are not going to spend money and go out, and are not going to have money or have a job if COVID is destroying our country. Coming from that perspective is really the only way that I know how to even begin talking to someone who's just doesn't have that kind of empathy.
Yeah, that's a good point. It's just public health is the way out of this, not the enemy.
What about strategies for dealing with and trying to convince vaccine skeptics? Because I think that's going to be the next great battle. I see we've talked about the forces of vaccine skepticism lining up, and already many of the COVID deniers come from that background anyway. So how do you convince a family member who watched some video by some OBGYN who appeared on Oprah and Dr. Phil telling them every lie about vaccines put together in a 3-minute segment? What's your strategy for dealing with those? And have either of you successfully talked anybody off the anti-vaccine ledge?
I mean, anti-vaxxers are a very interesting group. They definitely dig their heels in. It's really hard to convince an anti-vaxxer that they're wrong about, but honestly, the reality of the situation is vaccine injury is extremely rare. And when you offset, vaccine injury with the amount of injury that would have the disease itself would cause, the risk benefit is overwhelmingly in favor of having the vaccine program, right? But people always think of themselves as possibly being the worst case scenario, or their children, which as a mother, I understand that fear. I do. And but it is something that you have to make an evidence-based decision, and that's not what it's more of an irrational fear that's taking over instead of an evidence-based decision. And it's really hard to convince somebody that that's what they're doing. You know what I mean?
Yeah, vaccine hesitancy is an entire field of study within public health and medicine. And I don't study vaccine hesitancy, so I
Yeah.
really can't say. But I mean, just attacking someone for their views because it is really frustrating, I totally get, but we know that shame doesn't really work as a tool
No.
to convince someone to vaccinate themselves or their children. So I'm not really sure what the solution is. For me and my family, although I'm the youngest in my family, I still I try to be ahead of the curve I've texted my family a couple times like, hey guys, there's these QAnon conspiracy theories going around. Just
Cut it
don't
off at the
believe them.
pass.
Yeah, just like warning them like, hey, like don't believe these things because they're a bunch of BS. So I mean, talking to the people I know is the only thing I know how to do. And then of course, educating through TikTok is what me and Kat do. So.
Mm-hmm. I don't want to miss this opportunity of talking to somebody who's involved to some extent in the policy or the public facing side of things, Maddie, to ask about the whole gym situation. I've gotten a lot of heat from talking about how gyms are potential super spreader locations. The argument being, that you produce a lot more aerosols when you're huffing and puffing compared to when you're not doing anything. The one study I saw said like 10 times more aerosols and droplets when you're talking loudly as opposed to talking quietly. And if you're doing Tabata interval sprints on the concept rower, you're going to be spraying droplets all over the places. And there are more and more examples of super spreader events at gyms. But how do you control this, and how do you deal with the poor bastard who put his life savings into developing that gym and pays his mortgage and puts food on the table by running that gym or running that karate studio or running that jiu-jitsu studio? Like, it's just seems like an impossible situation for those people.
It really is. And that's why I think dealing with COVID, preventing COVID is the most important thing. If we would have properly had a lockdown in the United States and would have properly given people resources and business owners, small business owners, the resources to keep their businesses afloat through that lockdown, then I think we'd be in a very different situation. So with gyms, they can particularly be dangerous because people are breathing hard and they're indoor spaces. So any indoor space, like a congregate setting where people are indoors, is simply just going to be more dangerous than something with better airflow, right? Also with COVID, you don't have to have symptoms and you don't have to be an unhealthy person to be infected and to spread COVID. So I know some people are confused because at one point, some public health expert, I think from World Health Organization, said that there was no asymptomatic spread, but what they neglected to say is there was significant pre-symptomatic spread. So pre-symptomatic spread is when you don't have symptoms right now, but you will develop them later on. And you are infected and you are likely transmitting to other people. And so you can go to the gym, healthy as can be.
Sorry, I'm just going to jump in there. So that WHO official was distinguishing between pre-symptomatic, where you are going to get sick, and asymptomatic, where you're never going to get sick. Is that correct?
Yeah, that's the distinction, but pre-symptomatic spread really is asymptomatic spread. It's just kind of a nitty-gritty definition thing that we do in public health. But when talking to the public, we should really acknowledge that you can spread disease without having symptoms. That's the bottom line here. And so gyms can be a dangerous place, especially when masks aren't required. If someone's not wearing a mask, that's just not a good situation to be in. However, we have to understand that, so for me, for example, it's just not worth it for me to go to the gym and go to my yoga class. Like I can skip out on that. But for other people, the gym really is like the sacred, really important part of their life. Not to mention the people that are gym owners and their income relies on it, or they work at a gym, and so their income relies on that facility. And so that's the really unfortunate part of this pandemic, is that our incomes often rely on these like non-essential businesses. And so what we have to do here is
you are going to get
risk.
a ton of hate for that statement, because the gym owners are all busy saying that their businesses are essential, that physical health is essential, that if you're in good shape, that you're going to you have a much better chance of surviving this virus. How dare you say my gym isn't essential?
I'm sorry, I didn't mean it like that. So if we're really going to go with what's essential, it's like food, water, shelter, and healthcare. Anything else, for the sake of this conversation, obviously gyms are really excellent places to improve health, and in public health, that is one of the most important things. It's something we've kind of put on the back burner since COVID, but prevention and exercise and healthy eating are absolutely one of the things that we talk and think about the most in public health. But during this crisis, the year of this crisis, and for the next few years, obviously, it's just not at the forefront of our minds, right? But anyway, for a lot of people, they rely on the gym as like an income source and whatever. So what we have to do is be able to mitigate the risk of COVID transmission within gyms, because clearly we're just not going to shut them down for a year or 2 years straight. We just can't do that because people rely on them. And so the CDC has guidelines on how to do that. For if anyone's listening that's a gym owner, they have gym and fitness center employee recommendations. And really the best thing to do is be able to set up your facility, your business, in a way that your patrons or your customers don't really have to think too much about their actions. So of course, the mask thing, that's something that they have to think about, that they have to have and should be required to enter. But what I mean by they shouldn't have to think about their like decision making is, instead of just keeping all your equipment super close together like usual, you should, if you can, move those machines around, spread out more, so that naturally people, they don't even have to remember to not go on the exercise equipment right next to somebody else. They can just naturally do that because they're spread out. So yes, we need to focus on decreasing transmission in gyms without necessarily having to shut them down.
Yeah, I think there's kind of a false choice often between do everything, which would mean shut the gym down.
The false dichotomy. Yep.
Yeah. Well, this is the year of the false dichotomy.
Absolutely. But that is definitely one of them, is that everything is being called a lockdown. And yes.
It's a curfew. It's not a lockdown. You have to wait in line and only have 15 people in the store. It's a lockdown.
Yeah.
Well, but in the gym and fitness environment, people are like, either I have to close or I go ahead completely business as normal. And this is especially prevalent in the jiu-jitsu environment that I operate in part because jiu-jitsu is essentially like struggle cuddling. You are literally 2 inches away from your opponent, fighting as hard as you can, breathing as hard as you can. It is the perfect. Somebody sent me a message today. I used to joke that jiu-jitsu was the perfect way to spread this virus other than group sex, and then a bunch of swingers clubs got shut down, and I got all those messages going, hey, see, your prediction came true. But to drag this conversation back to the realm of respectability, I think that if you were a gym owner and you said, we are the most COVID aware gym in town, we only train in pods of 2 or 3 people, and we only open up when the percent positivity rates are going down, and we've improved our ventilation, or we train outdoors, and we contact trace everybody, and we take everybody's temperature. Not, temperature taking is probably not that important, but we do it anyway. And we actually, talk to our people, and if you are out partying, we're going to kick you out. If you came to it from that point of view, you'd actually bring more people in who've like walked away saying, screw this, I ain't having any part of your flat Earth, germ theory denying, uh, COVID denying, WHO conspiracy bullshit. I'm out of here. You'd actually bring those people in. So I think there is a middle position to be had. I think it's way trickier in a jiu-jitsu situation than in like a gym with a bunch of treadmills. Maddie, would you have any, or Dr. Wallace, would you have any suggestions for like particularly high risk activity? No, I mean, jiu-jitsu is kind of a niche thing. Uh, Swing dancing, right? We talked about swingers, so we're going to talk about swing dancing, totally different thing. What would you tell the owner of a swing dancing studio or a partner yoga studio or any place where there's extreme close physical contact and that's just part of the sport or that's part of the recreation?
That's really hard.
It's really hard. Yeah.
When people are in direct contact with each other, that's the highest risk.
That's
right?
how the virus spreads.
Because that's just simply how it is. But I think my advice would be to talk to other owners and other people in the thing that you do, whether that be dancing or whatever. Because what we've seen through this pandemic is business owners and people in general have been really, really creative in finding ways to do things in a slightly more safe way. So even though it might not be possible to have it's not possible for anyone, but it's not possible to have a 100% COVID risk-free situation.
Yeah,
but if you can mitigate that risk, if you can decrease the risk, that's really what we want to see.
Yep, I agree. And it's basically how many layers of Swiss cheese can I put in? So if I'm at a dance class, maybe I can't social distance 100% of the time, but I can wear a mask. Maybe we can have the ventilation improved somehow. I think that's really important.
Maybe you can have one partner instead of doing the round
robin
thing.
One partner instead of a million people. Maybe you can put a HEPA filter in the room that circulates and cleans
the air.
Or do it outside. Anything to improve ventilation. Just the more, like, the Swiss cheese model is so important because it helps people visualize that it's not just one thing that's going to prevent COVID-19, and you're never going to like eliminate a risk when you're with other people, but you can mitigate it. You can measure that risk, and the more layers you're able to put into the activity, the safer it's going to be.
Do you think the metric of dialing up your precautions and dialing down your precautions and possibly closing your gym versus opening your gym, depending on what the percent positivity rates are doing, do you think that's a useful gauge? Like people talk about, we only have more cases because we're doing more testing.
Oh, yeah.
To which the counter argument is, well, look at the percentage of all the tests that are positive.
So the percent positivity does not change in an area just because we're testing more. That is a COVID myth. We've seen basically, for example, in my area over Thanksgiving weekend, our testing N dipped, but the percent positivity stayed the same. So it is really like you need to think of it in relative to the denominator of how many tests are being done, not just how many tests are. So the argument is very simplistic. It's like if I go fishing and I take a scoop of fish, like I'm going to catch more fishes than if I use a small net, like, right? But if you think about it in terms of how many fish are in the pond, like it's different, right? So you have to really think of it in terms of that. It's not, so percent positivity is a very useful measurement because it's like taking the temperature in the community. It's like basically like a cross-sectional measurement that just kind of shows out of all the tests that are being done, this is how many are positive today or yesterday or 5 days ago. Or like, as Maddie alluded to, there's a reporting delay and there's lab delays. So what you're seeing today in your case numbers is really what happened like 3 to 5 days ago, sometimes more, depending on where you are. So it is useful because it kind of tells like what's going on in your area. So I do understand that it's tough for business owners, and I do care about that. But if your area has like a 15% positivity, like some parts of the country right now, do I think it's a good idea to be dancing around with people that you don't live with? No, I don't.
Well, I mean, it's in parts of South Dakota north of 50%.
I mean, right now we're not even recommending people like hang out with people they don't live with because if you look at the COVID map right now, most of the country is red, and we've actually put a new color red on the map now. It's like a maroon because we have so many cases in some areas that we need to distinguish that from other places. So it's like we have two levels of red now. So we're not really recommending people to do group activities. I mean, it's not going to be like this forever. Like Maddie was saying, this is science in action. We have to kind of follow the numbers.
Okay. We've been going for a really long time, and it's been amazing amounts of information. I have just one more question. And given that you guys are both out there and both, exposing yourself and the information, but you're exposing yourself to criticism, and I'm sure fairly vicious criticism. I can only imagine your inbox, knowing what my inbox looks like. What are you guys doing to stay sane? Like, how do you stay balanced and not just want to like start the morning with whiskey and end it with bourbon?
We send each other texts all the time about crazy comments. We have actually a nice little group of TikTokers that we've become friends with just from meeting just other science people that we've kind of have a little community now, which is really nice. And it's been because we're all kind of going through this together, and it's something that none of us have ever done before. Like none of us have ever been TikTok creators, and none of us have ever gone through a pandemic. So it's sort of a very unique thing that we're all going through together, and we all get sometimes the same trolls coming on our pages. Yeah. So we're like, oh, it's that guy again, like we can all kind of commiserate, and it kind of makes it
block them.
Yeah, it makes it okay. Like it's and a lot of them are just so ridiculous. It's just like you said, like some of the conspiracy theories are just so easy to be like, yeah, no. Or you just don't answer. But some of the ones that are more abusive, I will block because I don't need that. And, but most of the time I just ignore them because they just are there for attention.
Maddie, anything to add? Any secret Maddie Lewis strategies for not going insane?
Yeah, I've just been trying to not focus on people's individual behaviors, people being irresponsible, because
that's
the reality is people are just irresponsible, and they're going out to bars, they're going out to parties, and they're having a huge 20 people Thanksgiving and whatever. And I just try not to focus on it because there's really nothing I can do. Even as a health department worker, there's just I have no power over that. And so all I can do is advocate to legislators and online the best I can. So I just try not to focus on that. The trolls really are insane.
That's a really good point, though, is like people in our personal lives, like friends of ours, it's like you see them doing things and it really does give you anxiety, right? As an epidemiologist, you see these plans people are making.
Or you watch them get red pilled.
Yes.
Right,
I mean, I've had to
eyes.
just like unfollow certain people during this because I can't even look because it just makes me anxious. So
I deactivated my Facebook, actually.
So did I.
Because of the pandemic. Yeah.
I removed my Facebook
Black Lives
from my
and stuff like that.
Early on in the pandemic.
Because of anti-Black Lives Matter.
Right.
Sorry.
Right. Good catch.
Yeah.
Yes.
Yeah. I deleted Facebook from my phone, and that made a big difference.
I deleted everything because, like Maddie said, people's behavior during the Black Lives Matter movement, and then the way the COVID stuff, like it's just too much. 2020 has been a very powerful kind of visualization into what kind of people really are.
Yeah, in my better moments, I remind myself that people are under an insane amount of financial stress, health stress, political stress, and that they're being bombarded with information that's just stickier than the truth. They're being bombarded with things that have got the truth has got an R naught value of 1.0 0.01, and some rumor about what Dr. Fauci said in 2008 has got an R0 value of 10. And it's Brandolini's principle that bullshit spreads 10 times faster than the truth and takes 10 times more effort to refute.
I think that's true. And I think it's because the science is complicated, and it's hard to understand. And I think it's, if somebody is presented with either, reading scientific papers to understand mRNA technology, or believing that it's just all a plot to control me, the second one is easier to understand. Like, oh, well, it must just be this whole big thing, and I don't need to learn this other thing, because that's easy. It's easier for people to glom onto these conspiracy theories because the science is actually very complicated, and there's a lot of things I don't understand. So I rely on virologists and immunologists to help me through those things. But I think it's unfortunate, but I think that's kind of what's going on. Is it's a lot easier to believe that this isn't real and that it's all just this big conspiracy than to actually sit and face the reality that it is real and that it's very complicated and hard to understand. That's what kind of why we do our TikToks, right? Because it helps to take the scientific literature and kind of fill this chasm between science over here in the academic building with the layperson who's just watching TV and hearing about these things, maybe on Fox News, and hearing, like you said, Alex Jones talking about something, like just knowing what there's a huge in between those two extremes, right?
I've got to imagine that the conspiracy theorists, or most of them, have never actually worked in a large organization, that they've mostly been in their mother's basement watching YouTube videos. If you've ever worked in a large organization, you know that this idea of having everybody singing from the same song sheet, or even doing the same thing, is almost impossible. The analogy I use in the fire department is one of the simplest things you can ask somebody to do is to ventilate a building, right? To smash a bunch of windows, say on the backside. And if I tell a crew that's competent, with a competent officer, to go around the backside and smash the windows on the second floor, there's nothing simpler. But the odds of that actually happening are maybe only 75%. Something's going to go wrong. They're going to screw it up. They're going to smash the windows on the ground floor. And to have 100,000 scientists and epidemiologists and virologists and immunologists all singing from the same page is impossible. I mean, I'm sure you've seen at the conferences, Kat, you put 5 scientists in a room and you have 10 opinions.
Yes, exactly.
Yeah. Well, thank you so much. I think stuff like this, doesn't have as high an R0 value as the conspiracy stuff, but I think it's really important. So I'm so grateful to both of you for taking your time on this ultra long
No,
COVID
thank you so
Q&A
much for
edition.
having me and having us on. It was really nice to talk about all this stuff.
Your TikToks once again?
I'm at Epidemiologist Kat on Instagram and TikTok, and I'm on Dr. Kat Epi on Twitter.
And mine is at maddy.epidemiology. So that's at MADDY period EPIDEMIOLOGY. That's a long word.
Awesome. Well, thank you so much, guys. And
thank you.
I'm really interested to see how 2021 rolls out, and I hope you guys are well.
I'm looking forward to a vacation. I don't know about you, Maddie.
A vaccine and a vacation is what I want.
The 2 V's. All right. Thanks, everybody.
Bye-bye.
Bye.